Everyone, thank you for your patience for getting our membership in. It's our June 3rd statewide substance response working group response subcommittee meeting, and welcome everyone. We'll go ahead and get the meeting started. We'll start with agenda item number 1, which is a call to order.
Chair Kearns, I can call the roll.
Please, thank you.
Assemblymember Ken Gray. Dr. Shayla Holmes.
Present.
Dr. Terry Kearns.
Present.
Nancy Lindler. Christine Payson.
Present.
Thank you, Christine. Senator Jeff Stone. Chair Kearns, given that all members serving in the Nevada legislature through the 2025 session are removed from quorum requirements for the duration of the session, we do have a quorum with 3 of our members present today.
Great, thank you. I appreciate that. As I said, good morning, everyone. We'll go ahead and move on to agenda item number 2, which is public comment. And at this point, public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. That's a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you're dialing in from a telephone, please dial 669-444-9172. When prompted, enter the meeting ID 868-3331-1069, and then press *6 so the host can prompt you to unmute. And members of the public are requested to refrain from commenting outside of the designated public comment period unless specifically called upon by the chair. Do we have anyone for public comment?
It's Crystal Duarte for the record, just because we're virtual only today, if you want to raise your hand to make public comment, I'm looking for anyone doing so, and we can take your comment. At this time, Chair Kearns, I do not see anybody raising their hand for public comment.
Okay, and we'll have another public comment session at the end, so we'll offer that again. We'll move on to the next agenda item, which is agenda item number 3, for review and approve the minutes from the May 14th, 2025 response subcommittee member. We'll start by seeing if there's any comments from committee members on those meeting minutes, or if anyone would like make a motion to approve.
This is Shayla Holmes. I'll make a motion to approve.
Thank you, Dr. Holmes. Do we have a second?
Christine Payson, I'll second.
Great, thank you. We'll go ahead and vote. All in favor, say aye.
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 Any opposed, say nay. Or any abstentions? Hearing none, it sounds like we have unanimous approval from the committee members that are present. So we will go ahead and move on to the next agenda item, which is agenda item number 4. This is a presentation on the Emergency Bridge Program. This presentation relates to a prior recommendation made by the Treatment and Recovery Subcommittee in 2024, which is to direct the Division of Public and Behavioral Health to identify a funding mechanism for hospitals and providers to enhance the bridge program for emergency departments by incorporating peer recovery support specialists into their treatment models. Support the use of peer support navigators via telehealth to increase access to treatment, and support for individuals identified in emergency departments. And then also there was a prior recommendation made by Treatment and Recovery and Prevention in 2022 and 2023 to expand access to MAT and recovery support for substance use disorder, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing bridge MAT, medication assisted treatment programs in emergency departments. That was treatment and recovery recommendation number 1 and prevention recommendation number 8C. The response subcommittee learned about the bridge program in July of 2023, and currently the prevention subcommittee is working on a recommendation regarding low barrier naloxone distribution in emergency departments. That subcommittee heard from national presenters and Dr. Morgan, who we will now hear from. Thank you, Dr. Morgan. We'll pass it off to you.
Sure, wonderful. Thank you guys so much for having me. I've gotten to present to a couple of your different committees as part of the team that is sort of working with us. And so I kind of want to give you guys an update of where programs are, where things are going, some of the challenges that we've continued to have, and we can kind of go from there. And what I'm going to share with you today is actually a presentation I shared with a group of healthcare administrators. So it was hospital executives, it was insurance company executives at a meeting back in February that kind of outlaid sort of the implementation plan and why they needed to get on board. So, and then we'll focus on a couple of the slides because I think they're probably most pertinent to what we're doing. So give me 2 seconds to share this. It's always like move the picture out of the way. So thanks for bearing with me. Can you guys see that screen okay? Or you're getting there? We got it? Okay, cool. So this is so again, this is a presentation that I gave to a bunch of hospital executives. The work was funded. It was done actually in collaboration with Bridge. Jeray Cantwell Frank, who's one of their EMS team members who's worked with Bridge for quite a while, came out and did this presentation sort of alongside with me, and we actually paired this training with an 8-hour day for EMS providers and some ER charge nurses on a train the trainer kind of day for implementation of how this plan is going to go forward. So those were the obligatory slides. I think everybody has seen the statewide statistics. This group is not naive to those, so I'm going to kind of skip over a little bit. But we were able to pull things off of the statewide database, even from 12/31 to 23. Here were some of the numbers for total hospital encounters, and how often we are seeing patients with substance use dependence within the emergency departments and within hospitals, because I wanted to make sure that I framed it in a manner that our hospital executives could understand that this wasn't something that they could avoid by just not participating in a program to bring access to patients. So obviously it affects the entire hospital. It's one in every 11 emergency department visits are made with somebody with a substance use disorder. Almost 12% of hospitalized patients have either SUD or unrecognized SUD, and it's a huge reason that patients leave against medical advice. These patients tend to have longer lengths of stay, higher readmission. So really getting to the nitty-gritty of it is that this continues to increase our own healthcare costs by not addressing their substance use problems. And it becomes, these patients a lot of times sometimes are difficult patients for hospital staff to deal with, and it causes conflict. And so it kind of set the stage. Challenges that existed then and exist now continues to be stigma. This is still a huge barrier within the hospital systems. And so a lot of our education efforts have stemmed around stigma. One of my nurse practitioners that I work with recently lost her son in March to an overdose, and she and I went and talked to our physician group specifically of what if it had been her son? You know, how many of us have seen her son in a different version of the patients that we see every day? And we found that that was a really impactful way to reach providers, is that this isn't somebody else's kid, this isn't somebody else's problem, this is an us problem, and it's kind of here to stay. And so the stigma and addressing the fact that really this is everybody has been very effective when we talk about stigma. And then we really talk about kind of the science behind addiction. The disconnect still continues between hospitals and outpatient follow-up. I think that the fact that our lists of providers continue to change every other week and who takes what insurance is a massive barrier to getting patients from the emergency department to areas of care. Mainly because we update things in a system and then they don't get updated for another 2 years. And so a lot of times the information that we're giving patients is not up to date. And I think that this is, for me, this is a key area where our navigators really kind of come into play. And then lack of understanding of kind of the process and how to get people on board and why they need to care about it. And really, when we're talking to hospital systems, we're talking to physicians, it can't just stand on the ethics alone. It needs to stand on, ties to the money and ties to reimbursement for what it is that they're doing. And so I think that that's where we've really tried to kind of hone in some of our efforts on educating people. So obviously, I think everybody on this call is familiar with the bridge model. It takes a clinical champion. We've identified a couple within several of the hospital systems. And one of the challenges around this work is, how do we fund a clinical champion? And that has been a massive challenge. I think right now I'm one of the only emergency physicians that is funded for anything. And even then, we had to use the PAC Coalition as a pass-through because nobody is paying any for-profit hospital or for-profit physician group to do the work. And so the mechanism to build the infrastructure has been a massive kind of problem. You have some great clinical champions, but nothing that they're doing is reimbursable. And so therefore the physician groups that are paying them, and sometimes the nursing groups, are not paying to have a substance use champion, similar to how we have a sepsis champion, or we have a stroke or a STEMI kind of coordinator, or somebody whose position it is to actually run that value-based model. We don't have that in substance use. And that would be one of the things that I would encourage this group to recommend, is that we need to kind of build more of a value-based metric around that to get the teeth into the system. So the navigators, obviously we have the patients, we know where they are. This is expanded into EMS as well, and this is being adopted in EMS systems across the country. It looks very different in several different kind of varieties. Some people are doing buprenorphine administration in the field, and I can talk about that in a second. The levodopa naloxone has been done for quite a while. Transport to ER alternate destination. The alternate destination has been very troublesome because the way EMS is reimbursed is by transport to an emergency department. Right now, there is no reimbursability for CMS to transport to anywhere other than an emergency department. And that was part of the ET3 model that kind of stopped going on. That was the CMS model to look at reimbursing for patients to go to alternate sites of care. And that ended up stopping short. And so we still do not have a reimbursement mechanism for EMS to transport these patients to anywhere other than the emergency department. So I think that would be something that I would encourage for our payers as well. And then obviously the warm handoff. We all know that Bupe saves lives. This is not news for this kind of group. So things that I have kind of planted the seeds with the hospital administrators is that I think that one of the stronger moves forward would be to put value-based metrics for reimbursement around our treatment for patients with substance use disorders in the same way that we do STEMI and stroke, and we certify these centers. Sepsis is an easy one. For anybody who's not familiar, sepsis is usually what happens when you have a source of infection that then travels into the bloodstream. You tend to have low blood pressures with it. It results in intensive care unit admissions. There's relatively high mortality rate. I would argue that we have high mortality rates, obviously, with our patients for substance use disorders. And so this may be an area not only to improve our overdose rates, but like our overall kind of treatment of these patients from a holistic point of view. But you're not going to get buy-in from the hospitals or from providers unless you put money behind it and you say, this is why it's worth your time. And so I would encourage a value-based metric similar. We have check boxes for sepsis. Did you give the amount of fluids? Did you give antibiotics within a certain time? Did they get, pressors started, within a certain time period if their blood pressures didn't respond? So those are metrics that every hospital has to meet in order to get reimbursement rates from CMS. So that is an area that I think that we could really kind of move the needle, especially because a lot of our patients have Medicaid, that we could encourage providers and hospitals to do the right thing. And that may look as simple as somebody is diagnosed with either an acute overdose or a substance use disorder. Was there a consultation placed for a navigator, which we now have available 24/7 on telehealth, which is actually a really exciting thing. So that was kind of the metric around what this looks like in terms of getting the hospital buy-in. I showed this to people. I'm like, look, there's all these codes that could apply. So pick your poison, but like there's lots of things out there that we can tie this to. And these all actually have reimbursement rates tied to them from CMS. So when I kind of looked at this and when I presented this, I said our roadmap to change is really integrating these things, and our state is already putting kind of some efforts into this. The pharmacy board obviously passed SB 325 back in 2021, but implementation has been a massive struggle for this bill to have pharmacists prescribe buprenorphine de novo. You'd have to basically educate the entire pharmacist population. They feel very uncomfortable doing this because there's no handoff. Where are patients going next? And so while the bill was good in theory, I think that we could tweak this to make it a little bit better. That it's a lot easier to extend a prescription that already was written by a provider rather than writing de novo prescriptions for a controlled substance as a pharmacist. I think you're going to get a lot more buy-in on that, but those are changes that have already been put into legislation here. Again, updates on the reimbursement and the return on investment for people. You know, how much money are you putting into a navigator, and then how much does that save the hospital on the back end? That was another kind of thing that I presented for people, and I think it's in the next slide. We should be adding addiction medicine consults as well to the delineation of privileges for hospitals. Currently, our hospitals do not have an addiction consult service, nor have they offered that as a delineation of privileges that somebody could apply for. So similar to, say, you have a toxicologist. So somebody with specialized information that a consult gets placed when somebody has a complicated overdose. They come in, they see the patient, they can still bill for these things. We do not have, as far as I'm aware, at least certainly not in Southern Nevada, there's not a single hospital that has a delineation of privileges around addiction medicine. So this is an easy area where we should encourage hospitals to provide that consult service, or at least allow for privileges around this. And that would make people more comfortable, you know, for managing patients on buprenorphine or methadone or things like that who come into the hospital for, say, surgery. Most hospitalists and most surgeons are very uncomfortable with how do we manage those patients, and having an addiction consult service would be extremely helpful. I think that since we have a fellowship here in town at Southern Hills, that should not be that big of a lift, in my opinion. And then obviously the telehealth services. So obviously statewide solutions, why we're doing isn't working. Obviously, we are really the only 24/7 access point for MAT and SUD patients. And the hospitals continue to be ill-equipped because they haven't bought into the return on investment. And so I think this is where the education efforts have focused. I argue that we haven't done our due diligence based on EMTALA because we're not really stabilizing their acute medical condition. So similar to, oh, they did bust in. Okay, dogs busted in and the cleaners are here. So bear with me that nobody gets eaten. There's 2 shepherds and a Connie Corso. So I don't know that we're fully stabilizing our patients. If we saw a diabetic, for instance, and we said, hey, you're in diabetic ketoacidosis, you need admitted to the intensive care unit, you need an insulin drip, and they say, no, I don't want to, or, you know, I don't think that you're worthy of the insulin drip, and you walk out the door, have we done our due diligence by at least not prescribing a prescription for insulin? I think that we have to reframe how we're looking at these patients from an EMTALA perspective, and I think that there's a lot to stand on from that stabilization standpoint. Obviously, these are some of the numbers that support the bridge model. Buprenorphine is the standard of care. Why don't we have a substance use SAR the same way we do STEMI sepsis, and that bounces back to the value-based care metrics. We know that patients who get buprenorphine within an emergency department have increased retentions in treatment at 78% versus 37%. And that was the kind of the hallmark study out of Yale that said, hey, we have a substance use clinic immediately next door. What happens if we give buprenorphine in the emergency department versus them waiting 12 to 24 hours for the appointment within the addiction clinic? Your retention rates dropped by half by having to wait the next day. And so this is why this is such an important kind of piece of that. And then the peer navigators, which hospitals have been really reticent to hire full time because they cannot make their money back on the reimbursement rates that are currently there. So this is why a broad spread telehealth platform and a way then to track that and get that information integrated into the hospital EMRs for then tracking value-based metrics, I think is so important. And this is what we're in the process of doing. So the system that we're putting in place, and this kind of is what really kind of ties it together, is we started with nursing education and started with provider education. And so residency programs currently train on this. What we're trying to do for the end of kind of this grant cycle. So this whole project is on state opiate response grant dollars. We're on year 2 of a no cost extension for this kind of project. Which ends the end of August, or technically the end of September, but I think the work ends the end of August, was really trying to get the nursing staff involved. And now we're backtracking even into the schools, the nursing schools. And I think that if we can continue to hit people earlier, we normalize the idea of it within the nursing schools and the nursing education. They now get it, especially for nurses who are going into emergency medicine. Or even on the floors, kind of that knowledge base. And what we have set up is we have QR codes with a 4 hours of free training off of the Bridge model. So it's off of Bridge Academy, which is free CMEs that they can get available. We have been educating the emergency medicine residents. So we're going around to the hospital physician groups here. We just did Envision in the end of April, and we're doing HCA. So kind of Sunrise, which sees almost half of the overdose patients for the state. HCA is staffed by Team Health, and we're doing their group in July. But everybody wants the plan already ironed out in place, so they just know what they need to do. So the warm handoff line went live 24/7 March 1st, but we have now had navigators in the hospital. They are at Valley Hospital 4 days a week right now during daytime hours, and then the warm line, or 5 days a week, I'm sorry. And then the warm line is active the rest of the time. That's currently staffed by Foundation for Recovery and a couple of other people who were just willing to help us kind of pitch in. But this is going to be a sustainability issue moving forward because this is grant funded. So this is the best way to kind of get widespread access to navigators within hospital emergency departments to best utilize their time and their skill sets without people driving from point A to point B all over the place and then running into hospital administration. I will tell you that it took 11 months after we had the funding in place. We had somebody hired. It took 11 months to get through hospital administration red tape to get the navigator on board. And I will say that one of the things that was, at least it was on my radar from a sustainability standpoint, and I have no idea if this is the right place to bring it up, but I'm going to do it, is that SB 378, there is a provision within that, I want to say it's section 18, number 3, looks at unsealing criminal records or having the potential to do that for anybody who may be billing Medicaid. And that could severely hamper sustainability efforts around peer navigators. If somebody says, oh, well, you have a sealed criminal record, or you had a record, we're going to unseal that, it gives people one more reason not to reimburse navigators under Medicaid, potentially. So I looked at that, and I'm just going to throw that out there. That bill went all the way through the assembly, and I believe is sitting with the governor right now as part of a massive healthcare bill. But just to kind of put that on the radar of this group, that potentially could kill some reimbursement efforts for a service that's so needed for this patient population. I don't think that was the intent of it when it got put in. It probably needs a carve out, but just so that we're aware that that is technically in there. So the warm handoff line is live. It is being utilized right now by hospitals across the valley. The number is out there. It has been given to charge nurses and nursing staff. And so now it comes into how are we documenting the services that are being delivered? And this has also been a challenge. When you have navigators who can now do things via telehealth, how do we get any of that information into the medical record? When navigators aren't hired by a hospital, they don't want to give access to the electronic health record. How do you prove that you've actually delivered a service that's done? And again, this looks at long-term sustainability. And so what we have, the workaround that we are working on getting over the finish line right now is actually using EMS software and the EMS medical record to basically carve out a navigator note, because EMS pre-hospital records can get pushed to any hospital. Like, so for example, we use ImageTrend with Las Vegas Fire and Rescue. I have an entire basically additional agency that I can put on, and those records can get transmitted into the electronic healthcare record of all of the hospitals in the same way that we do electronic health records for EMS. So it's kind of the back door to getting this done, but it would prove that services were delivered. So if in the ER we said, okay, great, I've got a patient who had an acute overdose, they're willing to talk to a navigator, I put in an order that says, please consult peer navigator, and that call happens, now I have a documentation mechanism to show that that service actually was delivered, and here was the little bit of a plan. And so there's a little bit of kind of workaround around the 42 CARA data sets that are allowed to be accessed, but I think it shouldn't really be any different than a case management plan in terms of where the plans were for the patient to go and just like the stage of change that they probably were at, so that if they come back to another emergency department, we can still access that record to know what the plan of care was. And that is a way to close the gap for documentation. So that's been a big lift. But that's one that right now everybody's struggling with nationally. And I think that this is a really easy way to pair technology that we already have in the field with EMS to bridge multiple hospital systems. So the prescribing plan, obviously all patients should live with a prescription for buprenorphine. The DEA has put, education requirements for anybody who has a DEA license and a controlled substance license. But again, providers are really hesitant to change things that they either don't understand why this is a them problem, feel uncomfortable prescribing the medication, and then a lot of times feel uncomfortable prescribing, especially for more than 3 to 7 days. And we know that a lot of times our patient population cannot get into outpatient care within 3 days if, they don't have access to transportation, they don't have an ID. There are barriers around picking up a prescription and being able to afford the prescription to pick up, having the transportation to get there, having the ID to get there, and then what do you do after that? And so these are kind of some barriers, and I think I've got at least one more slide that kind of talks about my ideas of how we kind of bridge this and what we need. So that's the kind of the prescribing plan. Since doing the education with the ER providers, we're getting more and more traction where people call me all the time and they're like, hey, so I think I have this patient. How do I do this again? Even though the protocol or the algorithm is like literally laminated and put near the computers, they still call, which is fine. Happy to answer those questions. But we're moving and we're making progress. It's just slow because you've got a bunch of really stubborn people. That's just the long and short of it. I'll call a spade a spade. So in order to push the physicians a little bit, we are going to start an EMS buprenorphine trial. This took a lot of buy-in and a lot of work because the EMS medical directors, some of them were a lot more hesitant. Well, what happens when they show up to the hospitals? I'm not comfortable with this medication in the ER, so why should I give it to my provider? So there's been a lot of kind of grassroots efforts, education around this. And what is coming down the pike is that Henderson Fire and Las Vegas Fire Q3 are starting a buprenorphine trial within EMS. And this will be available to every advanced life support provider to be able to give after an acute overdose. So this is a massive push forward. It's the first oral narcotic medication or first oral opiate technically on rigs. And so there's a massive education around the ER is why this needs to be an ER problem, how they can be part of the solution. And then it also it makes it much harder for ER docs not to continue that course if we've already started it in the pre-hospital setting. So it's kind of the stick and the carrot method. Like you can choose to do this, or you're going to get brought patients by EMS. We're going to help you do this anyway. So that is kind of the thought process a little bit around it. Obviously, the return on investment for the hospitals, the navigators, it improves hospital workflow, performance, provider satisfaction. It decreases length of stay. Like these are numbers that all came from Bridge. It decreased readmission rates by 30%. So if we're looking at it from a purely dollars and cents from a healthcare system standpoint, this is a really good thing. Decreased ICU and readmission rates. I think that the numbers from the hospital, reduced hospital costs is a really important one. That for the $343, basically, I think it's 9 hours of engagement of a peer navigator, the hospital save almost $18,000 a patient. So if that straight dollars and cents thing doesn't speak to you, I don't know how to help you. Because from a purely economic standpoint, most of our hospitals within the state are for hospital profit systems, and it comes down to bottom line metrics. And so for me, this is a good way to kind of present why it is that they need to buy into this process and make it as easy as possible. So the hospital administrators sometimes get it, but again, now you're talking about implementation science and operationalizing it across multiple hospital systems, and that's where it continues to get trickier. So there's a lot in it for them on the return of investment. So the things that I asked from the hospital administrators is their buy-in. I need them to champion things from the top down as well as pushing things from the bottom up, and maybe we can finally meet in the middle. And I think that this is kind of a big way to do it. Several of the systems have been willing to put education on their LMS platforms or their learning management platforms to make this mandatory education put out by the hospitals. But again, you got to get to the right people. It's actually got to get on. How do you track those numbers? Who's keeping track of that? The SURG grant that I currently have has money to pay hospital champions, but if anybody working in grant funding knows, it is slow. And so right now I have cash flowed this entire grant for the last 8 months. And I have yet to get a single check of reimbursement and didn't get a contract till 4 months into this work period already in place. So we have got to find another mechanism in order to build the infrastructure that is not a reimbursement kind of model. And so I would make the recommendation to this group that some of the local jurisdictional money, some of the state jurisdictional money actually pays for a position to direct infrastructure building and implementation, because it's really unreasonable to ask a single person to cash flow this and wait for reimbursement and give their time, money, and effort waiting for things to catch up. So that would be something I would recommend. I asked them about IT tracking. If you've ever tried to actually extract data out of an EHR or try to like collect reports, it's really stinking challenging, and the amount of permissions that you need is obscene. So this is also a barrier. And so I think that this is one more reason why we need paid positions and can put some value-based metrics around it. This will lead to the tracking data that you want to see how successful programs are actually being. I know that prevention talked about take-home naloxone, and Josh and I presented a little bit about like, this is not a hospital pharmacist problem. Like community distribution does not necessarily fall under a hospital pharmacist purview, but sometimes some clarifying language from legislation from the Board of Pharmacy, et cetera, is really helpful in kind of breaking down those barriers. And we presented that to prevention. But with that, I think that take-home naloxone is not enough. And one of my other recommendations is that it would be great to do a 3-day blister pack of buprenorphine so that anybody who has an acute overdose leaves with the buprenorphine in hand. Barriers to this have been the fact that hospitals are not dispensing pharmacies. And so there's a lot of kind of legislative and logistical barriers around this to providing a controlled substance directly to a patient in hand as they leave the hospital from a non-dispensing pharmacy. However, there is precedent for this. And that's kind of the cool thing, is that we gave out Paxlovid. So we would write an order and a prescription for Paxlovid from the hospital emergency department. And we had stashes on hand where we basically printed labels and attached it to that, and patients left with the Paxlovid. So I would make a very strong argument that I think that the same thing could be done with a 3-day prescription for buprenorphine, so that patients get that point of clarity and they are not worried about, how am I going to get the medication? I don't have an ID yet. I don't have transportation. And this is a way to really break down a massive barrier to patients getting care. So I think that that is probably going to require at least some sort of messaging from the Board of Pharmacy that an exemption can exist specifically for buprenorphine. We can do it in 3-day blister pack. Like, it can't be that hard. We figured it out for Paxlovid. We should be able to figure it out for this. And so that's one of my strong recommendations. And then I also asked them about coordination of other public health efforts for testing. But that's a bigger public health ask. So that is kind of how I broke it down. And hopefully that kind of gives you an update. Like I said, the SNHD trial is set to start Q3. I'm finishing up the little R research and study design definitions for them to say, hey, how do we know if we're going to be successful with this? And we're just going to do it because we know it's the right thing. And I can very confidently extrapolate the data that we've had from ER programs and what I already know about some of the EMS programs in the other parts of the country, and say, I know that this is going to be successful in driving change here in Nevada. So happy to take questions.
Dr. Morgan, thank you. I feel like you've been pushing the stone up the hill for quite a while, so we appreciate the recommendations. I'll open it to the committee members if there's any questions. Dr. Holmes, go ahead.
Thank you so much, Dr. Morgan. Like, that was, you took like a super complex medical system problem of which I had no understanding of, and now and you broke it down in such a way that I understand it now, and I think I could actually communicate about it. So I think that like thank you. So this non-dispensing pharmacy problem via hospitals, is this like a law that needs to change, or is that purely something that lives within the Board of Pharmacy?
So I think that there's like and I'm not the pharmacist. I literally like got all this information from my pharmacy friends, and I was like, help a girl out, you know? So what I understand is that the definitions of what a facility is licensed as, you're either dispensing pharmacy, so think like your commercial pharmacies, your Walgreens, your CVS, etc., or you have the ability to give a medication in a facility, but you don't dispense the medication for home. I think that from my understanding, that's the definition, and it has to do with how a facility is licensed But my friend was like, listen, we asked for an exemption and we got it during COVID for Paxlovid for the antiviral. So if we can say, this is a public health emergency, and we know that patients with substance use disorders actually making it to a pharmacy during hours, having the ID that is required to pick up a controlled substance, and having the money to pay for the prescription is a massive barrier for this patient population. This would significantly decrease the burden for patients with substance use disorders. Then I think we can stand on that argument, and I believe that can just be like a blessing from the Board of Pharmacy. So I don't think that actually has to be legislated, but the rest of it for what is a dispensing pharmacy versus a facility who gives medications to a patient in person is, I think, very different. Does that make sense?
Yeah, it absolutely does. It's got my wheels spinning on how we could, support this with the recommendation to either like a policy change or, whatever that looks like. So it sounds like there's a couple different avenues that could be attempted to make that change. But thank you so much for this information and your PowerPoint. Is there a way that, because I just scanned your QR code, is your PowerPoint in that?
I think so, but I'll send it to Crystal anyway. This is a presentation I gave at Game of Thrones, and then I gave a different version of this actually to Envision, and this is what will be given as well to HCA and to Team Health for Sunrise's group as well, because it's when you're talking to the people who care about money more than they care about the other stuff, you just have to frame it of like, this is what the reimbursement is. This is the money you're leaving on the table. This is why you need to do the thing. And then you hit them with the altruistic stuff of like, these are our family members and these are our friends and this is an us problem. So, but yeah, I'm happy to, I'll get this over to Crystal. Yeah, no, not a problem.
Any other questions from the committee? I had a couple, I guess, questions, comments. It's my understanding that nationally, for most states, overdose deaths have gone down, with the exception of our state, and I believe one other state from what I've heard.
I think it was Iowa. It was somewhere in the Midwest. Yeah.
Yeah, and that ours increased, it was just over 3.4%, which is small, but I've heard that part of the reason that they're seeing some numbers decrease is people have naloxone, so we're giving it outside, and not as many people are going to the emergency departments. So, which would really hinder some of the efforts you're trying to look at, but it continues, I think, in our state to be a public health emergency, to your point earlier. And it's my understanding that both the Bridge program and EMS dispensing or giving BUP are already being done elsewhere. So there's kind of that standard of practice or best practice. Is that correct?
Yes, it's getting there. Hennepin County rolled out buprenorphine to all of their paramedics in Contra Costas County and also in Newark. And then there's several programs across the country that are using community paramedics to do more bridge dosing, or they've had kind of more overdose response teams that show up that have kind of some additional training around buprenorphine. When I initially had this crazy idea, I said, let's use our community paramedics because that's probably the lowest hanging fruit. But we are short on resources, and there's not enough paramedics. We don't have enough providers. And so really this program is spread out such that really this should just be a medication that everybody has. And the way that we worked on framing it was that, we don't jump through 50 hoops when we say, hey, here's a new medication to treat nausea and vomiting. Here's a new medication. We rolled out IV Tylenol here in Southern Nevada. And there was a small trial around it, and we were looking to decrease, opiate usage in the pre-hospital setting. This was a great, easy, low hanging fruit for people to get their heads around. This one has been much more challenging because, again, the stigma is real. And I think that is the biggest barrier is stigma and people not understanding how to connect people to resources and not feeling comfortable with that process. So, but yes, it is being successfully done in multiple other places, and I've talked to all of the guys doing it. So, yep.
Thank you for that. And it's my understanding, we had a call, and I apologize, I can't remember his name, but the graduate from the Fellowship from Addiction Medicine and has presented to, I want to say, our treatment and recovery subcommittee about having addiction medicine as for privileges in hospitals, and then also increasing reimbursement rates. From what I remember him saying, they haven't been increased since like the 80s. So
Correct. Yeah, it was probably Jose, Dr. Partida Corona. Yeah. And I work with him, and his wife actually works within CCDC running their MAT program within CCDC as well. So yep. They're very intimately involved, and I think have they got some grant funding to do some other outreach programs, which is awesome. But yeah, it's exactly that problem. There's only a handful of true addiction specialists in town, and we need to be able to get them access to the patients who need them and consultation for those of us who get in over our head trying to manage patients who are on, long-term buprenorphine or methadone.
great,
Can I
thank
put in
you.
Can I put
Go
in
ahead.
one other plug? Can I put in one other plug that's not in my slides that would make life really helpful for us prescribing buprenorphine? Is that the PMP Aware site basically obviously tracks the prescriptions that somebody has for controlled substances, but methadone is not on there. And methadone within a 72-hour period is a contraindication for buprenorphine just because of all the pharmacology. Can we please push for methadone to be a mandatory reported dosing, because it becomes a barrier in the emergency departments when people say, yeah, I'm on methadone. And then we have certain pharmacists who call and make sure that they can confirm the dose. But a lot of those clinics are only open 9 to 3 on weekdays. And so these patients, a lot of times, if the pharmacist is not comfortable inpatient and can't get a hold of the clinic, there is no way to verify methadone dosing. And there's no way for us as providers or as prescribers for buprenorphine to be able to check the dosing and or figure out if they're on methadone, where we're going to cause problems starting buprenorphine. And so I don't know how that controlled substance magically got left off, but like that probably is going to need a policy around it.
Yeah, sounds like another Board of Pharmacy conversation.
Yeah.
I'll open it up once again. Any questions from any of the committee members? If not, thank you so much. We really appreciate your time, Dr. Morgan, and appreciate the recommendations that you made, which we'll take a look at.
Of course. Thank you guys very much for putting up with me and listening to me on my soapbox.
No, we appreciate it. And at this point, I think we're ready to move on to agenda item number 5, which is a presentation on medication-assisted treatment, MAT, and medication for opioid use disorder, MOUD, access in certified community behavioral health clinics, or CBHCs. And we would invite Mark Disselkoen, who's the project manager for the Center for Application of Substance Abuse Technologies, CASAT, at the University of Nevada, Reno, and Lori Follett, the Social Services Chief 2 with Nevada Department of Health and Human Services. So I will turn it over to Mark and to Lori.
Good morning. I believe Crystal said I could share my screen, so I'm going to give that a whirl. You're here. All right. Let me figure out where all my cameras just went, because that's always exciting too. It's like you push share and everything moves. Okay, so good morning. Thank you for having us. My name is Lori Follett, and I am the Behavioral Health Chief here at Nevada Medicaid, and I will let my colleague Mark introduce himself.
Hello, my name is Mark Disselkoen, and yes, I'm with CASAT in the School of Public Health at UNR. I'm an LCSW and LCADC, and I've been involved with the CCBHC project since 2016. So I've been around a bit on the CCBHC side. Great to be here.
So today we're going to talk to you all about Certified Community Behavioral Health Centers, or CCBHCs, here in Nevada. I know that this group specifically was interested in the substance use treatment options within the CCBHCs. However, I do think it is important to highlight the whole delivery model to paint that full picture. So our objectives today, we're going to go through a brief history of CCBHCs, the current landscape, who the current CCBHCs are, how you can become one, a summary of services, what our expansion model looks like, and our rate methodologies. And of course, at the end, we'll have an opportunity for some questions and answers. So Nevada's been building the CCBHC model since 2016. The Certified Community Behavioral Health Center program began as a Substance Use Mental Health Services Administration, that's a mouthful, or SAMHSA demonstration project. We were one of the first states to actually be chosen to become a demonstration within this program. And after the demonstration, Nevada was one of the first states to actually put this program into state plan. That, of course, solidifies it going forward as demonstration projects do end. So Certified Community Behavioral Health Centers alleviates the decades-old challenges that have led to crisis in providing access to mental health and addiction care. As an integrated and sustainably financed model for care delivery, this program ensures access to integrated evidence-based addiction and mental health services. They have to meet stringent criteria regarding timeliness of access, quality reporting, staffing, and coordination with social services, criminal justice, and education systems. They receive funding to support the real costs of expanding services to meet that need for care in their communities. So where are we now? I mentioned that we are currently functioning under a state plan amendment, which removed us from the demonstration. We submitted that in January of 2023, and it did take us almost 18 months to get that approved. That is how much fun it is to sometimes deal with CMS. And then during the 82nd legislative session, DHCFP we received budget authority to add additional CCBHCs statewide. And finally, that state plan was approved in May of 2023. And as of July of 2023, we are no longer part of that federal demonstration project. We are functioning fully under state plan authority. So who are our current CCBHCs? We are located all across the state. I believe now we have 10 full CCBHCs and 5 access sites. What's an access site, you might ask? This is an option for current CCBHCs to kind of spread their wings a bit, and they're able to offer up to 4 of our required services, with the patient having the ability to obtain all the services through that main location. For example, this works well in our rural areas. We have Rural Nevada Counseling functioning out there in Silver Springs. They have 3 access sites, which allows them to have touches into their communities in Dayton, Fernley, and Yerington. Those would typically be areas geographically challenging to get some services out to. So it has worked really well in that model. So who can be a CCBHC? Well, currently they have to be a nonprofit based on Section 223 of the Protecting Access to Medicare Act, or part of a governmental agency, Behavioral Health Authority, or an entity operating under IHS, so Indian Health Services. All of ours currently function under that nonprofit option. So what are the benefits? There's no prior authorization. I don't know if anyone has dealt with Medicaid recently, but the prior authorizations seem to be one of the things that really provide administrative burdens. They're also paid a PPS rate, which is a daily rate. So they're paid a daily lump sum versus a per code rate. So instead of getting paid $10 here and $7 there, our current average rate for a CCBHC is about $220 a day. They also have the opportunity to receive quality incentive payments up to 15% annually, and that is a multiplied off their total payments. They do have to meet metrics to be able to gain that. We have that substance use disorder and mental health treatment services, and all of them are evidence-based practice. They have to be SAPTA certified in substance use treatment, They provide targeted case management and patient and family-centered care. So the summary of services on the screen here, you're going to see the required services that are in all CCBHCs, with exception to those access sites that I spoke of. They can only administer 4 of these in an access site, but they do crisis services. They have a crisis number on their website, treatment planning, screening and assessment, outpatient services, the substance use services, targeted case management, outpatient primary care screening, community-based mental health care for veterans, peer and family support services, and psychiatric rehabilitation services. We also include assertive community treatment in our CCBHCs. I have on my next slide some helpful links that gives you links to our manual, our state plan, our billing guide, which also includes our allowable services. So the allowable services are what can be billed through a CCBHC and obtain that daily rate. And it's important to know that they only have to provide one of those services to be able to claim that daily rate. So as I spoke of, that reimbursement rate is similar to kind of maybe an encounter rate you may have heard of, but those are billed using that daily rate. With doing so, they also bill with a modifier. And as I mentioned, the allowable services grid allows us to have a lens into what's actually occurring into these clinics versus just them billing a daily rate and us not knowing what's happening. So it gives us that lens inside. Currently, all the CCBHCs in rural areas are billing fee-for-service Medicaid, and CCBHCs in Washoe and Clark County are mostly billing through the MCOs. I'm sure you guys have all heard that Medicaid is going statewide managed care effective next year, so we do expect that model to change as we roll into that. They are required to shadow bill. That's the lens I just spoke of. This allows us to track costs over time and hopefully track cost savings. I believe now we are going to give this over to Mark. He's going to talk a little bit about medication-assisted treatment.
Very good, thank you. So just wanted to provide, what are the specific requirements for our CCBHCs related to MAT. So the CCBHC standards, which are SAMHSA standards that we adopted for the state of Nevada. We also have additional requirements beyond the federal standards, but this speaks very directly to medication-assisted treatment. So this is the brief summary, and if you want to read it in more detail, you can obviously go to the actual standards. But essentially, CCBHCs are required to have a medically trained behavioral health provider that can do medication-assisted treatment, not just for MAT for somebody with an SUD, but also medication-assisted treatment across the board, regardless of what the condition is. And Lori talked about this earlier. They have to be able to do medication management for children, adolescents, and adults. Okay. And that would also be to treat any kind of mental health condition as well. But we're more focused on SUD today. So the individual or individuals need to be employed by the CCBHC or have through formal arrangement or agreement with a MAT provider to be able to provide those services. So we have what we call them care coordination agreements, also designated collaborating organization agreements. So it has to be very formal. So if they cannot provide it themselves, they need to be able to provide it to another entity. With that said, all of our CCBHCs have at a minimum a psych APRN that is able to prescribe at least buprenorphine, naltrexone, those types of things. Obviously not methadone, because that would be in a methadone clinic. I'll talk about that in a minute. So who can prescribe and manage medications such as this individual, either on-site or through coordination, be able to prescribe buprenorphine and other FDA-approved medications for opioids, alcohol, and tobacco. So across the board there. Methadone can only be prescribed at a licensed opioid treatment program. And I think everybody in the state of Nevada knows that they need to be licensed by Healthcare Quality Compliance as a narcotic treatment program. I wish they would update that name, narcotic treatment program, but they still have it from years ago. so forth and so on. None of our CCBHCs are a licensed narcotic or methadone clinic, but they do have care coordination agreements with local methadone clinics to be able to provide those services. So our CCBHCs, like I said, at a minimum, need to provide MAT utilizing buprenorphine and naltrexone, okay, which is very important. Also, our CCBHCs, and Lori noted this, they have to be SAPTA certified. SAPTA certification has kind of an updated name. It's called the Behavioral Health Certifications for Excellence in Nevada, BHCEN. The acronym is supposed to be BCEN. That kind of is replacing SAPTA certification, just so people kind of are aware of that. That's a recent name change. We certify all the CCBHCs at a minimum under ASAM level 1 withdrawal management, which means when we do our clinical reviews, we do look at clients that are on MAT, and we determine that they're, that they're getting the care that they are needing, so forth and so on, through that certification. So that's kind of like an additional certification beyond just the standard CCBHC certification. And why level 1 withdrawal management? The reason for that is obviously when somebody's on a medication for a substance use diagnosis, that medication has helped managing their withdrawal syndrome, obviously. So that's why we certify them at that level of service and look at that. Next slide. So I think everybody kind of knows what this is, but I just wanted to throw it up there because I'm not ever sure what the audience is. And this group seems very well away and educated, and you have physicians on this group. But just reminding people that methadone being a full agonist, that's why it is managed at a higher licensure level under HCQC, as well as the federal requirements. They have to be DEA licensed. They have to be a board of pharmacy approved. They have to be nationally accredited by like Joint Commission. They have a lot to do to be able to dispense methadone. Just to remind everybody, every methadone clinic also subscribes Suboxone, Subutex, as well as naltrexone. Most of them do. Not all of them, most of them do. So it's not that methadone clinics just do methadone. Obviously, buprenorphine, Subutex is the mono, buprenorphine naloxone is the combo. And then naltrexone, Vivitrol is injectable, and Rivia, for example, is oral. And some of our methadone clinics, actually, when a client comes in and they get them on naltrexone, sometimes they will do daily dispensing of Rivia rather than get them on a 30-day naltrexone injectable, just to make sure that they have a good stability, that they're accessing additional services. So that is very, I think, a very efficacy way of doing things. And then we've been talking a lot about naloxone, and obviously naloxone, all of our CCBHCs and treatment providers typically have free access to naloxone through the SOR grants and so forth and so on. So the next slide, I think probably everybody may be aware of all of the current methadone clinics, but I wanted to put them up here. Las Vegas, North Las Vegas, Henderson. You can see the Treatment Finder webpage on this slide. Actually, that's a website that CASAT, on behalf of the state, the division, manages, and it'll show you all of the certified licensed methadone clinics, as well as all treatment services in the state of Nevada that are certified. Right. There are other providers who are not certified, but this website will show you that. So that just gives you kind of a list of all that. Just a quick note on Seven Hills Behavioral Institute. They do maintenance and withdrawal management only. They do not do induction, but they are looking at starting to do induction, which would be really good. So some of them aren't like traditional methadone clinics such as Seven Hills as well. Next slide. This is just Reno Sparks area and Carson City as well. These are the licensed certified methadone clinics. And so just a quick note on that. I talked about all the federal requirements. They're also required to be licensed by HCQC. They are also certified by SAPTA, now BCEN. And really the SAPTA certification really focuses on ASAM levels of care and programmatic kinds of implementation, whereas HEQC really focuses on health and safety. So we really get into, they have to provide level 1 at a minimum ASAM, level 2.1 as well. And we look very closely at the psychosocial services that go along with the medication-assisted treatment to make sure the individual is receiving holistic care. So that's kind of a quick overview of MAT. Just to go back to the CCBHCs, again, they're required to provide it either on-site through one of their prescribers or through a warm kind of care coordination agreement with an outside provider. And we do confirm that. If there's ever any concerns about any individuals being denied care because of MAT, please let Lori and I know. We will double check and research that. We do have specific SAPTA certified, BSEEN certified criteria that says that no individual can be denied access to care based on being on one of the FDA approved medications. So we do have leverage, and if we ever find out that somebody is being denied care due to that, we do follow up with that and investigate it. So I wanted everybody to know that as well. Next slide.
More slides. I think it's also important to share with this group that CCBHCs, prior to becoming one of those clinics, were our substance use disorder providers here in the state. So they do have a long history with substance use and the treatment. The current CCBHC team, and when we talk about that, we do regular on-site reviews. The touch on these providers from the state level is very high. It includes a team from Medicaid, or the Division of Healthcare Financing Policy. We have the Public and Behavioral Health, as well as Healthcare Quality and Compliance, that does our certification. Of course, we have the clinical expertise from the folks at CASAT. And we do go out there annually to make sure that their notes are correct, their coordination agreements are correct, that they're following their treatment plans that they have in place. So we want to make certain that they're doing this to the fidelity of the model. So the touch is very high, and some people like that level of oversight and others do not. So there's that part. But we do have opportunity for you to ask us questions should you have any, and we also have our contact information for you if you have questions after we leave you today.
Lori and Mark, thank you so much. It was enlightening. I know I learned a few things. I will open it up first to our committee members to see if they have any questions for you.
I have just a quick question.
Please.
So one, I would just like the other presentation, if it's possible for us to get your slides, that would be fabulous. On your list of 9 required services.
Yeah.
All CCBHCs, I just I'm seeking super clear verification here. All CCBHCs are required to provide all 9 of those services. And to obtain the daily rate, they just have to do one of those a day to get the daily rate. But they have to offer and have all 9 services available all the time from their core site, not their satellite site, but from their core site.
Yes.
You're correct.
And just to clarify, there are times because of staff turnover, we know there's just a workforce issue in the state of Nevada, that they may lose a peer support specialist or a TCM. So we work very closely with them to make sure they follow up and they, fill that gap and get that individual hired. They often will contract sometimes with another CCBHC to help them in those windows where they may lose staff. So they are required to provide those 9 services, but as you know, if you lose staff, there may be a gap for a period of time, right, related to that. But we work with them very closely on that to get them, up to speed and get somebody, hired and so forth and so on. To the point where if I notice that when we're doing a review, they're having a hard time with turnover, we actually have them address that as part of their continuous quality improvement plan. What are you doing related to staff retention and also outreach to hire people and stuff like that. So we work with them on a very, intimate level to try to address those staffing issues in the state. And if there's ever an issue where, it appears that a provider or CCBHC is not providing a service and they're telling you that they don't have to, or they're not currently, please let Lori and I know, because we will immediately follow up and deal with that. And this is the difference between like this being, providing like enrolled and you're doing Medicaid and you're kind of picking and choosing what you do. It's not a choice of the CCBHC. If you are not providing all of the 9 core services, typically you'll get put on a plan of correction. And over a period of time, that does not get rectified and fixed, we will move to decertify them. And we have decertified a couple of CCBHCs for that very reason, that they were unable to provide the 9 core services consistently over a period of time.
Thank you so much for providing that explanation. Much appreciated.
I see Christine has her hand raised. Go ahead, Christine.
Hi, forgive me if I missed the slide or looked at it wrong. When you had it up about the statewide methadone clinics, I only saw the ones in the northern part. Do we not have one in Clark County? Or did I
Oh,
just
yeah,
miss
it
that?
was that slide before that.
Okay,
There was 2
figured. I'm like,
slides,
I
sorry
must
about
have looked away and missed something, but I just want to be sure. Thank you.
Yeah, it's there. Yeah. And there's a lot more in Clark County, obviously, than the rest of the state. So yeah, the list is there. So.
And I appreciate that you all are really trying to make MAT more accessible to our rural and frontier counties. Is this the max, or could we potentially see more in our rural and frontier counties, is my first question. And then the second part is, under the MCO, is it just a reimbursement type of issue and not an expansion of services?
So under the, it's technically we can expand CCBHC statewide. We currently don't have a limit to how many we can enroll. Obviously we want more in our rural areas. That would be our goal. And that's why that model that Rural Nevada Counseling has implemented has been helpful, because in some of those communities, it may not be financially sound to set up a full one. As we've discussed, it's expensive. And it's a heavy lift. So yes, we're looking to reimburse for rurals if we can get anybody who's interested in playing with us out there. On the other question with regard to MCOs, our current MCO contract is written to where they have to reimburse them at least their PPS rate. So they cannot contract with them for less. They could contract them for more if they wanted to incorporate other types of services into that clinic model. I don't think I've heard of anyone doing it, but that would be the possibility. It is an administrative burden for the state, for Medicaid, to not have them paid that minimum rate, because then we have to talk about wrap payments and things like that. And that just gets messy for our fiscal staff, as well as the providers. So in our last contract, that's how it was written. Does that answer all your questions? Okay.
It does. Thank you so much. And
You're
again,
welcome.
we really appreciate you coming and explaining what is a complex topic and making it in terms we all can understand. So
Absolutely.
thank you. And seeing no other questions, we'll move on to the next agenda item, which is agenda item number 6, which is an update on wastewater surveillance of high-risk substances in our state. And we have Daniel Garrity, who's a principal research scientist with Southern Nevada Water Authority, and Edwin O, who's associate professor with neurogenetics and precision medicine lab out of UNLV.
Great, thanks for having us back. Yep, there we go. All right, so I'm going to provide an update on the wastewater surveillance work we've been doing. But first, I want to start off looking at the public health side of it, and then I'm going to connect it to the wastewater. So this is some opioid overdose mortality rates per 100,000 people here in Clark County, Nevada, then across the United States. And then what I'm pointing out here is the increase not only from 2019 to 2020, but also from 2022 to 2023, which overlaps with the wastewater data that we generated during that same time period. And I'll come back to that on the next slide. And the other thing I wanted to point out was the overall overdose deaths in Nevada. And this is showing data points for the preceding 12 months. And so what I wanted to point out here is that there's been an overall increase even in most recent years, including 2023 to 2024, but there's some signs of it slowing down and potentially even decreasing if we go out further into the future. And so what I wanted to do is connect that to what we've seen with the wastewater data. And so in this slide on the left, we're first looking at what I was talking about from 2022 to 2023, when there was a considerable increase in opioid overdose rates in Clark County and across Nevada. And so what you're seeing here, these are norfentanyl concentrations in wastewater in different sewer sheds. And I'll show the map in a second on what these facilities represent in terms of Southern Nevada sewer sheds. But what I'm pointing out here specifically is that before October 2022, there was only one sample that we had collected across Southern Nevada that was above our method detection limit for norfentanyl. But then if you fast forward to October 2022, that dividing line, something definitive happened where almost every sample that we collected beyond that point now had detectable concentrations of norfentanyl. And so that lined up with the overdose data that we were seeing on the previous slide for opioid overdoses. Now on the right side, this is related to the overall overdoses in Nevada, where we saw it slowing down and potentially decreasing. Now what you're seeing here, this is also wastewater data, but this was generated by a company called BioBot through their NIDA funding, so National Institute on Drug Abuse. They received funding to look at wastewater concentrations of a bunch of high-risk substances across the nation. And these data are showing the national averages in blue, and then the concentrations that were actually detected in Southern Nevada. And similar to the overdose data, what you can see here is that there's a somewhat of a plateau in the norfentanyl concentrations. And then in Southern Nevada, you actually see that big drop that was happening in that summer of 2024. Unfortunately, that program ended at that point, and so we don't have more recent data showing what happened. Did that decrease continue? Did it come back up again? We're not sure. But at least in the data that we see in the wastewater here versus the overdose data on the previous slide, there seems to be a correlation between those two. And now taking a step back, I referenced the sewer sheds. So on the left, you're seeing the map of Southern Nevada broken up by the sewer sheds that we were looking at. And we do that by going to the centralized wastewater treatment plants in town. And the top left picture that you see there, that's an auto sampler at one of the centralized wastewater treatment plants. And so we would go every 2 weeks, collect a sample that looks like that, and then analyze that for the high-risk substances. So that's some of the data that you were seeing with norfentanyl in the previous slides. But more recently, we've expanded to other sampling locations. And so as you go upstream into the collection system, you have to collect those samples in slightly different ways. So what you're looking at there in the middle, top middle, is a peristaltic pump that we're using to do a manual grab sample in a manhole. In the bottom, that's Catherine Crank, somebody who's working in our R&D group as well, collecting a grab sample using a telescoping sampling pole. And then in the top right, you can see a more recent composite sampler that we purchased, and you can deploy that in a manhole. So it hangs down from that metal bracket, and then there's actually tubing that goes down into the manhole, and then it comes on at certain times to collect wastewater as it's going through. And so that gives you potentially a more representative sample because it's collecting over, let's say, a 24-hour period, as opposed to a grab sample that's just a point in time. So looking at that, the centralized wastewater treatment plants, again, this is going back kind of a recap of what you've seen in the past. And again, what you're seeing here is the norfentanyl concentrations in these different sewer sheds across Southern Nevada. It's just presented in a slightly different way. And so we're looking at distributions of concentrations in each sewer shed, along with detection frequencies here along the bottom. And then you see these dots here that represent outliers. So these are potentially problematic spikes that are above what we typically see in a given sewer shed. And so again, connecting it back to the public health data, what we saw is sewer shed 2, which is Anthem 7 Hills, the least likely to see norfentanyl in the samples that we collected during the sampling period, versus sewer shed 3, which is City of Las Vegas, where we were much more likely to see norfentanyl and at higher concentrations. And again, that corresponded with the overdose data in those particular sewer sheds. So lower overdose rate in sewer shed 2, lower norfentanyl concentrations and detection frequency, and vice versa for sewer shed 3. So again, that's just a recap of what you've seen in the past. So in the last update, we talked about Fund for a Resilient Nevada and funding that we were pursuing to look at wastewater surveillance in a more localized context. And so this is a collaboration with Dr. Ed O, who's on in the meeting today at UNLV, Dr. David Hannigan at University of Nevada, Reno, Dr. Doug Sims at CSN, and then our group here at SNWA. So trying to branch this off across the entire state. But again, looking at more specific locations and more specific demographics. And so this one was focused on youth and transitional age youth. And in this year one that is coming to an end, there was a shortened year one, almost over at this point. We focused more on transitional age youth by looking at college, university campuses, and then bars and nightclubs based on the sampling locations that we had selected. And then potential public health actions that can go along with this, awareness outreach programs, naloxone deployment, fentanyl test strips to bars and nightclubs, for example. So one example that I want to provide, this is a project flyer that we generated early in the project so that we could pass out to public health partners, for example, or anybody who had interest in what we were doing. So for example, if they saw us out sampling and had questions, we could pass out this flyer that provides some statistics about overdoses in Nevada, where you can find more information about this particular wastewater program, and then frequently asked questions related to wastewater surveillance. And we can provide this flyer if anybody's interested. So the location that I'm going to talk about here is the one that SNWA has been sampling and analyzing over the past few months. So this is Nevada State University's campus, and you see a map, an overview of the Nevada State campus here on this slide. And the circles that you see, the red circles, represent manholes that we selected to try to kind of isolate certain aspects of their campus. So we have a west manhole that's capturing most of the academic buildings. We have a south manhole that's allowing us to isolate the student housing complex. And then we have an east manhole that's a blend of the student housing complex and then academic building 3 and the student advising center. Top left, you can see what it looks like when we're out sampling. So just before this meeting, that's where I was out there collecting those samples today. It's getting hot again, so it's not the greatest time to be out sampling in Nevada. And then the south manhole here, this is actually what it looks like inside. So you can see that there's a line that comes from the left, and then there's a line that's coming from the student housing complex from the bottom. And so by focusing on collecting samples from the bottom,
Okay.
from the bottom here,
What's up?
that's how we can collect that sample that actually isolates that student housing complex. So those are the 3 locations that we've been doing every 2 weeks. And so what this looks like is we'll go out Sunday, Monday, and Tuesday mornings. We'll collect those samples, drop them off. So for example, I dropped off the samples this morning with our research chemist. She analyzes them by Tuesday afternoon, and then we typically share the results with our project partners Wednesday morning. And that includes the Nevada State University Student Wellness Center, City of Henderson's Mobile Crisis Intervention Team, and then Southern Nevada Health District as examples. So what does the data look like? So I'll break this up a little bit. So we have all of our target compounds there on the left. We have the middle 3 data rows includes the overall detection frequency at those 3 locations that I just described. So what percentage of the samples that we've collected so far have been positive for that particular compound. And then on the far right, what you'll see is in the most recent week of samples. So these are data from about like 3 weeks ago, I think. How many of the 3 samples that we collected in that given week were positive for that particular compound. So to break this down, the most important parts, no detections of fentanyl, norfentanyl, or xylazine at Nevada State in all the samples that we've collected so far. However, we have seen heroin and/or its major metabolite acetylmorphine in 2 separate weeks at the student housing complex manhole, and then also in the manhole that's downstream from that location. So it shows some consistency between those 2 locations. But again, with that south manhole, we're able to isolate the flows that are coming from the student housing complex. And then another thing that I'm pointing out on the right side here towards the top, in the most recent sample event, not only did we collect a grab sample, but we actually deployed those auto samplers for the first time. And in the grab sample, like I mentioned, it's a point in time. And so if you're not capturing that sample at the exact right time, you might miss a signal that would otherwise be captured by a composite sampler that's collecting over a broader time frame. And so what we saw in this particular the example is that the grab sample was negative for acetylmorphine, but then the corresponding composite that collected over that 24-hour time period actually had a hit for acetylmorphine. So it shows the value of doing composite sampling when that's practical and when an auto sampler is available. So that's just a snapshot of what we've been seeing at Nevada State, and we're hoping to generate similar data sets across other campuses across the state. And then the last thing that I wanted to end on here is EDC. So I'm showing data from 2024. I can't remember if I presented this the last time we had an update, but starting off in the top left here, what you're seeing in blue are the wastewater treatment plant concentrations of MDMA or ecstasy. So again, this is the centralized wastewater treatment plant, the largest treatment plant in town, 100 million gallons per day. The red, what you can see is maxed out in this particular graph, and I'll come back to that in a second. But we're looking at based off of multiple collections within the EDC weekend. So a sample collected on Friday, Saturday, Sunday, Monday, or a Monday grab. And because the samples are collected, again, these are composites, so it's collected over a 24-hour time period. What we're seeing in the Sunday sample actually reflects what happened Saturday throughout Clark County on the Las Vegas Strip, for example. So you can see a dramatic increase in that Sunday sample because people were consuming ecstasy, excreting it to the wastewater system, and we saw that reflected in the wastewater at the wastewater treatment plant. If you come over to the right, the reason I have two versions of the same graph is because the concentrations at the EDC manhole, so near the speedway, were astronomical compared to the wastewater treatment plant concentrations. So the wastewater treatment plant concentrations are on there, you just can't see them because the manhole concentrations were so high, which is not particularly surprising. So again, Saturday, we start to see more ecstasy. Sunday, especially, again, this is reflecting what's happening on Saturday. We have that major spike at nearly a million times higher than we normally see in a sample like this. So that's ecstasy. If we come down to the bottom right, now we're looking at norfentanyl. And so the blue again is the wastewater treatment plant. And so you can see pretty consistent, maybe a little bit of an increase in norfentanyl concentrations coming into the wastewater treatment plant during this time frame. But then going to the red again, this is norfentanyl from the Speedway site at the EDC festival. Friday, non-detect. Then we have our first hit on Saturday in the Saturday sample, and then it goes up a little bit more and then starts to come down. And so we definitely had norfentanyl hits coming out of that the festival grounds during this time frame. And so this is 2024. We actually just repeated this because EDC just happened. We repeated the sample collections and the analyses. And when I submitted the presentation, we didn't have the data, but we do have the data now, and it basically looks exactly the same. So we have the big spikes in ecstasy, which is not surprising, but then we also have the norfentanyl hits in basically the same samples. So non-detect on the first sample, and then we start to see hits throughout the weekend as more and more people are going and consuming high-risk substances and so forth. So it basically, it shows the value of, we can understand what's happening in terms of people's behavior, and then in terms of the real public health targets like norfentanyl, we can see how much consumption of fentanyl was happening during that same time frame. And so we'll have a summary of those data available in the near future once we start putting these comparisons together. So with that, the remaining slides, there's references, contact information for Ed and myself if anybody has questions outside of this, but we're also happy to take questions now.
Thank you for coming back and providing an update for us. I would open it up to committee members if you have any questions. And let me just, for my own edification, my understanding is you meet with your partner agencies after you have the data, so that helps them with targeted harm reduction activities. Is that correct?
Yes, so let me come back here. So we've met with the City of Henderson Mobile Crisis Intervention Team. We had a separate meeting with them where we explained wastewater surveillance and the data that we're generating, what it means. And then when we generate the data every 2 weeks, we have a summary that looks like the next slide that we send out with our interpretation of the data. So they'll see the updated data, what we think personally about the data that was generated, and then we leave the response up to them. As far, I'm not sure if any responses have been undertaken because of the data, but that's where kind of where we stop, and then they pick up what's going on.
Great, thank you. Again, any other questions from committee members? Hearing none, I thank you again. Appreciate you coming back, and we look forward to seeing more as your project goes on.
Yep, and thank you for your support so far.
At this point, we've hit the 12:30 mark, which is supposed to be the end of our meeting. So item number 7 on the agenda is about discuss proposed 2025 response subcommittee recommendations. And I believe you were provided a separate document that has those outlined. There have just been 2 so far. Quickly, Dr. Holmes, if you'd like to go over your recommendation just real quick, just to present it.
Sure. My recommendation is, as so eloquently put on the slide, I can write better than I can talk most of the time. But ultimately what I am hoping to get us to, and one thing that I love about our process is that we work together to change it and amend it to be something that's like feasible or reasonable. So ultimately what I'm getting at is an attempt to make some clear laws in our state that prohibit the over-the-counter sale of any illegal substance like substances, because there's this loophole or this big I'm losing my words this morning, but market, for lack of a better word, of over-the-counter products that have been altered in some way to bypass laws. And so individuals are able to purchase illegal like substances over the counter, and many of them have no age restrictions whatsoever. So our youth are able to purchase them. The problem comes down to the language, right? Because what happens is we create laws using specific words and specific chemical makeups. And so then these substances get altered slightly by really smart people, right? Like you heat something up and it changes what it is. Those are like the chemists out there in the world doing these things. But then next thing you know, they end up on the market for sale with no legal recourse, and our youth are able to get a hold of them, and they can be very dangerous, many of them more dangerous than their original illegal counterpart. So in attempts to try to figure out some language around that to get us started would be to prohibit the sale of all psychoactive substances, including hemp-derived cannabinoids and psychoactive mushrooms, to individuals under 21 years of age, to align with existing cannabis regulations, and implement clear labeling standards, mandating that all products containing psychoactive compounds have standardized labeling. Right now, many of them are listed as like mood enhancers. And so the lay person without any, wherewithal may purchase something and then have an experience of which they did not intend, including clear warnings about potential health risks and age restrictions, and then also restricting the sales locations, because right now many of them are available over the counter at like the Sinclair. Like you can go to like the AM PM and buy stuff, and it's all sitting right there. It's like the energy pills and all that stuff, and many of them contain some pretty dangerous things. And also limiting the sales of the substances to licensed establishments where people have to verify the age of purchasers, prohibit the sales near schools, the laws that go with all the other illegal substances, to just make these a part of those categories and figuring out what that language is. And I'm not like the originator of this thought process. I made the recommendation. I don't know if any of you have ever heard Tall Cop do his presentation. I've heard Tall Cop several times over the years. And 10 years ago, Tall Cop was telling us about how to identify marijuana and what the marijuana stash pockets look like. And I'm certain he still has presentations on that, but the most recent one that I heard from him was really focused on these over-the-counter substances, because people are dying and our youth are able to access them And while, you know, we may or may not be able to impact what individuals over the age of 21 want to partake in if it is legal, but I think we have an obligation to attempt to protect our youth from access.
And I was just going to add, I remember hearing from the YRBS, the Youth Behavioral Risk Survey, that they had to change a question on it because the question was about illegal substances. And the answer was, well, all of these are legal. Well, they're legal for adults, but not for people under certain ages. So, you know, it kind of gets to the point of what you're doing, I think, as well. Okay, we'll go ahead. I'll just briefly talk about my recommendation. And basically, this is to revise our recommendation about state agencies under the legislative, judicial, and executive branches involved with deflection and diversion programs have a comprehensive definition of recidivism and policies related to measuring and reporting recidivism. This recommendation is to also include desistance, which is something new that I've just recently heard about. And basically, the desistance is really more looking longer term and looking at kind of not returning to the criminal justice and antisocial behaviors and behaviors that would lead to criminal behaviors. So I heard about this out of the Washoe Sheriff's Office. So my recommendation is basically to have them come and talk about this as more of a mechanism to measure the impacts as of these programs. So look forward to that. Probably a lot more. They can go into depth with what they're doing out of the Washoe Sheriff's Office, but just again, another way it has to do with reentry programs and how to better help those that are reentering from coming out of our prisons and jails. So we'll move on to the next one. I would highlight for members, please look at the handout that Crystal provided that has more in-depth information in it. But for out of time, this is at this point just a discussion and no votes required. We'll move on to agenda item number 8, which is our response subcommittee meeting topics. And we do have these topics: workforce from Dr. Hunt, defining recidivism, as I've just discussed with the Washoe County Sheriff's Department, drug and alcohol prevention, education, and enforcement. That's Officer Jermaine Galloway, which is the tall cop, which is who Dr. Holmes made reference to. And currently our meeting dates are August 5th, September 2nd, November 4th from 11 to 12:30. But I do want to highlight to the members that AB 19 was amended on timelines as well. So if you'll remember, AB 19 was to increase the membership of the SURG, but in some discussions with legislators, there was a recommendation to change the timelines to make it more actionable and aligned with timelines for departmental budgets and legislative deadlines. So what that means is that the 2025 annual report, which would be due the end of January of 2026, would describe the process for developing our recommendations. But then in August of 2026 and every August thereafter, the annual report will include our final recommendations. So I think some of you know we weren't able to get people to sponsor some that were BDR requirements from our last one. So that's really why this recommendation was made. So my understanding is it made out of both sides, but it needs to go to the governor's office to be signed. So hopefully that will go through and would give us more time for our recommendations. So then that comes up with the question of, would we still need to meet monthly, or could we go to every other month? So that might be something. Crystal, is that something that you could send out a survey or an email and find out how the members feel about that?
Yeah, I can definitely do that. And I think we talked about getting an update or information from other subcommittees as well in July, so that all the subcommittees are moving forward in a similar manner. They don't have to all have the same meeting timelines, but Just want to make sure the committees do move forward consistently. So I'll recommend that for the other groups as well.
Great, thank you. But I just wanted to highlight that for the members because that is a big change to the way we've been doing things. Any questions or comments from committee members on that? Or other topics? Seeing no one go off mute or no hands raised, we'll go ahead and go on to the next, which is item number 9, which is public comment again. And we will open it with all the same requirements. Public comment can be received via Zoom by raising your hand. All the same information. Does anyone have any public comment?
Terry, this is Sherilyn Marwood.
Yes, please
I
go
can't get my
ahead.
hand to raise on my computer. A little crazy today. First of all, thank you for this meeting. Always very beneficial, always great presenters. So I want to thank you for that. Thank you for the last 2 presenters too. I think that was great information to give today. I want to say that AB 60 is sitting on the governor's desk as well, and that's codifying certified prevention specialists. So something you guys should be excited about. So we hopefully will see some signature happen pretty soon, and then we'll work on those codes and regs of what that position really looks like and what work we want to do here in Nevada. So we'll be looking for some people to step forward when we start writing those regs and codes and really looking at what do we want our CPSs to really do now that they're actually codified. I also want to say Thursday at 2 p.m. is the Northern Regional Behavioral Health Policy Board meeting as well. And what we're going to spend that day doing at that meeting really is just going over the bills that are on the desk, kind of look at that and have a discussion. So higher level of report out on the bills. And that's pretty much what we'll be doing at Thursday's meeting. So just wanted to put that out. But again, thank you for this meeting. And those presentations today were awesome. And I agree with both of your recommendations. Shayla, yes, that was awesome. And Terry as well, still moving forward on recidivism. I appreciate that.
Great, thank you for those comments. Anyone else for public comment? And if you can make Sherilyn's meeting on Wednesday, it's always very informative as well. At this point, we're on agenda item number 10, which is our adjournment. I thank you for staying with us for going 12 minutes. We got out early last time, so we took that time back today. So thank you, and we'll see you at our next response subcommittee member meeting.